Hi, welcome to our lesson on cancer and cancer care. This exemplar falls under the concept of cellular regulation. This is something from way back in anatomy and physiology that you learned, where the cell is the basic structure of the human body and it serves a specialized purpose in the body. So with cancer, this is a disruption of that normal process. So cancer is quite common. You'll definitely see it in your career, probably regardless of what specialty you decide to work in. It's the second leading cause of death in the world, and unfortunately that's only expected to increase over time. So even though we've gotten better at treating cancer, we're not getting better at stopping it from occurring. So this can happen to anyone, right? There's a mutation which happens to all of us in the body. Usually our body's pretty good at detecting that and getting rid of it. But in the case of cancer, the body does not recognize that cancerous cell. It goes undetected, and then it begins to grow and it divides until it's lost its similarity to its parent cell, its original cell. The problem then becomes if that begins to spread and goes to other areas of the body, that's called metastasis. That can eventually lead to death. So we stage cancer on a scale of 0 to 4. So 4 would be the most severe. That's when those cancerous cells have gotten into the bloodstream or the lymph nodes, and now they're spreading to other organs, attaching themselves there, and then they've kind of become their own being at this point. There's a lot of risk factors. You've probably heard the term carcinogens. These are risk factors that are out in the world, things like radiation, where prolonged exposure can cause cancer over time. Some environmental factors, this might be pollution or contaminated water. Some hormones, so this can happen, the incidence of this can increase with age. So some cancers are hormone dependent, things like breast cancer or prostate cancer, for example. Some lifestyle choices will increase the risk of cancer, so obesity is a risk factor, or a sedentary lifestyle, for example. There are a lot of infectious diseases that can lead to cancer. So, for example, cervical cancer is almost exclusively caused by HPV virus, and H. pylori can lead to stomach cancer, or HIV can lead to Kaposi sarcoma. That kind of ties in with the immune system too. So if somebody has an immune system that's not functioning quite like it should be, like in the case of HIV, or maybe autoimmune disorders where they're taking immunosuppressants, that's going to increase the risk of cancer. And then nutrition plays a factor too. So our diet in the U.S. Is a prime example of a risk factor for cancer. So high protein, high animal fat consumption, lots of sugar, those are all diets that can increase the risk of cancer. So the clinical manifestation really depends on what type of cancer it is, but these are just some general things that might be helpful in determining cancer. This is a nice little mnemonic that might help you. So any change in bowel or bladder, especially constipation or urinary retention, and if that's new, not something you've been dealing with your whole life. Any sore that does not heal, so maybe it just keeps crusting over, it's just not getting well. Any unusual bleeding or discharge, so this could be from the bowel, it could be vaginal, especially if for a female, if they've already gone through menopause and now they're starting to bleed. Again, that's a big warning sign. Thickening or lump, so this could be a tumor, right? And it feels a certain way. It feels hard. It's not spongy like a cyst. It doesn't move easily. It's kind of anchored in, and it's usually non-painful. Indigestion or trouble swallowing could be an indication of esophageal or mouth cancer. Any obvious change in a wart or a mole, so let's say you've had this freckle your whole life and now it's grown twice its size and the color's changing, that's a warning sign. Or a nagging cough or hoarseness. We diagnose this a number of different ways. We can do laboratory tests, depending on what type of cancer it is. We may do imaging like x-rays, MRIs, ultrasound. We can do a PET scan, which will look at the whole body and let us know if there's metastasis of cancer. Our definitive diagnosis is going to come from the biopsy, where we take a tissue sample and we look at it under a microscope and we can tell if that cell is cancerous, if it's changed. Endoscopic procedures might be colonoscopy or an endoscopy or a bronchoscopy, where we're scoping it, looking at that, and we can also get tissue samples that way too. So treatment depends on the type of cancer it is and what stage it is, and also what our goal of care is. So maybe the goal of care is not to cure the cancer, maybe it is to keep this person comfortable. So if we already have somebody who's stage 4, and we know we're not going to be able to cure that, then maybe we just need to think about some palliative care options, giving them quality of life, which may include chemotherapy and radiation. So remission, would be nice in every circumstance, but it's not always possible. And even if somebody does go into remission, we don't always necessarily say they're cured because it could reoccur. So they have to be monitored pretty closely for the rest of their life. So there's a lot of surgical options. For some cancers, we can just go in and completely remove that tumor and those cancerous cells, and hopefully that will be the end of it. But depending on where it is, that might not be a possibility. We may be able to debulk it. Even if it's not cancerous, if it's a benign tumor, we may still go in and remove it just because it's uncomfortable or doesn't unsightly, or maybe it's pressing on other organs and causing problems. So radiation is pretty common treatment too. This can be external or internal. So some things to think about with external radiation, they're going to probably be getting temporary tattoos because we want that beam of radiation to go to the exact same spot every single time. So we need to make sure we tell them not to wash off that temporary tattoo, and just to be very careful because there's going to be radiation burns at that site, so they need to be washing with mild soap and water, not hot water. Don't lay out in the sun. Don't put a lot of lotions and perfumes there unless you've checked to make sure that they're okay. Internal radiation is going to have its own special precautions. This is called brachytherapy sometimes. And this person's going to be emitting radiation. So some things to think about: if they're being hospitalized, they need a private room. They shouldn't have any visitors under the age of 16. They shouldn't be visiting for longer than 30 minutes. Nobody pregnant should be coming in. And whoever does come to visit should keep a distance of at least 6 feet. And we want something on the door with all of these precautions, easily readable, so that everybody's following the same thing. And even nurses who work on units, like cancer care units, they usually wear a dosimeter to let them know how much radiation they've been exposed to, so they're not getting too much radiation, which would increase their risk of developing cancer one day. Lots of medications that we will give in this situation. We'll talk about these more in class together. There's a big category called anti-neoplastics. This includes chemotherapy, immunotherapy, which is becoming a really big emerging field in cancer care, hormonal agents. Sometimes we battle these hormonal cancers with hormones. And then we can also sometimes do stem cell and bone marrow transplants for some types of cancers. Something to think about when you're giving these chemotherapy medications is that if you're giving it IV, they can be vesicant, meaning that they can cause extreme damage to the surrounding tissue if they leak outside that blood vessel. So we cannot give this through a peripheral IV. It has to be a central line. If we know somebody's going to be getting chemotherapy for an extended period of time, they'll usually go ahead and place a port in the chest for easy access, and that's considered a central line. So hopefully you'll get a chance to see that, in the lab or maybe at clinical. But we still need to make sure that we're assessing that site pretty frequently, so that if we notice any signs of extravasation, we can stop that infusion immediately, notify the provider and the pharmacist. If there is an antidote, we need to give it right away so we don't lose that tissue. And then depending on which type of medication it is, we may need to do a hot or a cold compress. And then, of course, document, because if you didn't document it, you didn't do it. So you know that by now. If you do work on a unit where you're dealing with these hazardous chemotherapeutic drugs, then you just need to follow recommendations from the manufacturer and for the facility that you're working in. There'll be a lot of protocols there and personal protective equipment that you need to be wearing. You might need a special gown or even a hood, special gloves, double gloves, so be very careful. You don't want to be touching those things and absorbing those medications, because that's then going to increase your risk of developing cancer one day. And then any type of waste, so waste of the patient that's getting that medication or that radiation, and the wasting the drugs. You can't just dump that stuff down the toilet, right? It has to go into a specialized container. There's a lot of complications with cancer. These are just a few. Of course, our biggest concern is metastasis, where it's spreading to other organs. Anorexia and cachexia is a big problem too. This is one of the big warning signs of cancer is unintentional weight loss. Anorexia cancer in itself can cause an anorexia, where just the general loss of appetite. But then also think about, the cancer cells are stealing nutrition. This person may be under stress, which can cause a loss of appetite. And then there's all that nausea and vomiting as a side effect of those medications that we're giving. So all of that can cause an extreme weight loss, which leads to this cachexia, where it's almost like a skeletal state. The nausea and vomiting is one of the worst effects of this chemotherapy. We kind of expect that to happen. They're very harsh, so we need to be giving antiemetics routinely. Even if necessarily they don't need to ask for it. We know that they're going to have nausea. We should go ahead and give it before they get the nausea, before we give the medication, those chemotherapy medications. And then think about other things you can do for nausea, like making sure you're getting rid of bad smells in the room, giving them cold foods versus hot foods, smaller meals, not giving liquids with meals, things like that. Yeah, dry foods are usually better, like crackers, things that are easy on the stomach, not a lot of fatty foods or spicy foods, which can increase nausea. The thrombocytopenia is an effect of the chemotherapy medication, because the chemotherapy causes bone marrow suppression. So they don't have those extra platelets that they need, so they're going to be at big risk for bleeding. So in class we'll go over bleeding precautions that may need to be instituted, especially if their platelet count drops below 50,000. The most concerning effect of chemotherapy is the immunosuppression. So for suppressing the bone marrow, that's going to cause a lack of production of white blood cells, to eventually to the point where maybe they don't have an immune system to fight anything anymore. So our big worry there is that, in the process of treating this cancer, we cause a problem where the immunosuppression, is so bad they get a simple infection, and that causes them to die, in the process of treating this cancer. So be very careful. You may need to think about instituting neutropenic precautions, which may also be called protective precautions, or reverse isolation, depending on where you work. So we'll talk about that more in class too. And then the third part of this pancytopenia, this bone marrow suppression, is the anemia. So we need to be watching to make sure they're not getting too anemic. Then there are some emergencies, the hypercalcemia, especially with bone cancers, all that calcium gets dumped into the cells, so we need to be looking for dysrhythmias, spinal cord compression, so look for numbness and tingling. Superior vena cava is when there's something pressing on that superior vena cava and it causes a backup of blood, so that could cause pulmonary congestion or edema, upper body edema. SIDH we talked about in class, so make sure you watch the video on that. That's common with lung cancer. Tumor lysis syndrome is when the cells split open and dump their contents into the bloodstream, so you need to worry about potassium and calcium levels with that. And then paraneoplastic syndrome is an overreaction of your immune system to the cancer. So we'll discuss these a little more in class. Make sure you do your reading, and I will see you then.